Thank you for joining us today for ID Care Live. Welcome to the Pediatric Infectious Disease Clinical Symposia series presented by Johns Hopkins University School of Medicine at ID Care Live. Today is the first segment in a four-part educational series that will explore issues related to the evaluation and management of persistent pediatric diarrhea. Today's session is titled Current Concepts in the Evaluation and Management of Pediatric Diarrhea, Is This Clostridium difficile? With Dr. Colin Marchant. My name is Dr. Elizabeth Barnett, and I'm Professor of Pediatrics at Boston University School of Medicine. I'm pleased to serve as the chair for this important educational program series. Today's session is a live, interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd like now to introduce my colleague and today's co-presenter, Dr. Colin Marchant, Associate Professor of Pediatrics at Boston University School of Medicine.
Thanks, Elizabeth.
Colin, thank you for joining us today. I'll now hand the program over to you.
Good afternoon, everybody. We're going to talk about Clostridium difficile. Why would we want to do that? Well, there's a number of points why it's a particular topic of interest. First of all, there's increasing morbidity and mortality and an increasing incidence in pediatrics patients. Secondly, there's been the emergence of toxigenic strains that produce more toxin than historical strains have done, and this can lead to more serious disease, so we have to be on the lookout for serious disease. Thirdly, there's a high rate of colonization in infants and young children, and this poses a problem as to when a test is really a positive test or merely represents colonization. So we need to be very judicious about doing tests for C. diff toxin in young infants and children. Clostridium difficile, what is it? Well, it's a bacteria, gram-positive anaerobic bacteria. It's a bacillus, and it occurs both in toxigenic and non-toxigenic forms. The toxins, labeled toxin A and toxin B, are the principal actors in causing disease. Typically, these bacteria are going to live in the colon, but when there's an inciting event disturbing the intestinal flora, particularly antibiotics, then there may be an overgrowth of Clostridium difficile with the elaboration of toxins and causation of disease. Transmission of Clostridium difficile occurs by spores and ingestion of spores through the fecal-oral route, and it's important to know that these spores are long-lived and widespread in the environment. On the next slide, I'm going to show this in a schematic. So on the box labeled box 1, the spores can come from anywhere. They can come from your hands, they can come from your skin, they can be in hospitals and homes, in soil, animals, food, air. The number of sources are enormous here where C. diff has been reported. For example, in dogs that are in hospital visitation programs in children's hospitals, if you culture their paws, you'll find there's some C. diff amongst those paws, for example. So they could be anywhere and come from anywhere. So then you ingest them, and in box 2, now they get into the colon, and the spores then turn into the metabolizing vegetative form of the bacteria. If there's lots of other microbial flora to compete with them, they just sort of hang out there in the colon without causing too much trouble. But when along comes an antibiotic or perhaps other factors, then the C. diff may overgrow, become a dominant species, and start to produce toxin. That toxin can damage the colonic mucosa and, in the most extreme form of disease, form a pseudomembrane in what's called toxic megacolon. So this is the basic cycle of the pathogenesis of Clostridium difficile. I said earlier that the incidence has increased, and in Children's Hospital this has occurred since 1997. Various studies have looked at this. Increases have been from 2.4 to 4 per 1,000 admissions in 22 children's hospitals, 20,000 cases. Other studies, 7.2 2 to 12.8, whatever, but always increasing in these studies. The reason for this increase is not totally clear. Is it because of increased diagnosis and suspicion, or is there a true increase in disease, or both? We can't quite be sure. There has, however, been an increase in more toxigenic strains of Clostridium difficile. The most notable one has been called NAP1, and this is characterized by its nucleic acid sequence, and it is a hypertoxin producer. It produces 16 to 23 times more toxin than historical C. diff strains. That's because it's missing a regulatory gene that keeps toxin production in check. In adults particularly, it has caused increased mortality in many places in the world, including the United States. And this may be with lots of recurrent disease, with toxic megacolon, with bowel perforation, and there's been an attributable increased mortality rate in adults from this strain. In our pediatric isolates, it's about 10 to 19%. It can occur in children who have been in healthcare facilities or have not, or who've had antibiotics or have not. But it's not all strains, it's just some of the strains. It's important for us to know this because it means we need to worry about the more toxic forms of this disease, but it doesn't actually influence our clinical care because we don't measure the strain itself in basic clinical practice.
Dr. Marchin, I understand you saying that we may be starting to worry more about this colonizing children who have no exposure to healthcare settings. Is that correct?
Well, it's correct that it may come from children. It may appear in children that have not had those exposures. But still, most of the time, we're not worried about it being a widespread epidemic as such, only that there's potential. These strains still may be held in check by our own microbial flora, even if we ingest them. It doesn't mean automatically we're going to get them. It just means they're out there. So, the other point that I mentioned at the beginning of this presentation was the issue that many children are colonized or so-called carriers with C. diff. It's notable that 26% of the hospitalized children with C. diff are less than a year of age, yet many, more than a third of people in this age group are colonized. Is this true disease or is it asymptomatic carriage? That's our challenge. C. diff rates in infants range around 37% in the first month, 30% 1 to 6 months. Other studies, it's been not quite as high, but it's clear that it's higher. By 3 years of age, or perhaps a little older, we return to the adult levels of colonization, which are only 0 to 3%. This means that with such a high asymptomatic carriage rate in the first 3 years of life, we cannot assume that C. diff is the causative agent. Perhaps we shouldn't do it even until adolescence. I'm going to show you now a study that puts this in as a visual. This is a pooling of the data on the colonization rates from almost 6,000 patients in the literature. And the age groups are a little bit uneven, but it shows you the high rates 0 to 15 days, and in the first 6 months of life up to a year, the high rates that I mentioned, they decline. Still age 1 to 4, the studies that have been done show a higher rate, and that gradually declines. So this visually tells you that you've got a lot of people with this organism, but that aren't sick from it at that time. So who gets disease? I've already been mentioning antimicrobial therapy, and I'm going to mention it again, and it won't be the last time in this talk that I mention antimicrobial therapy as a principal inciting risk factor here. But there are others.